So once again, my name is Stephanie Gadbois on behalf of the entire team of the Economic Club of Canada. Welcome. Before we begin, we are reminded and we respectfully acknowledge that we are on the traditional territory and home of Indigenous people, the Wendat, the Anishinaabe, the Haudenosaunees, the Chippewas, and the Mississaugas of the Credit First Nation, land steeped in a really rich history dating back many generations. The purpose of our acknowledgement today is to show our gratitude and our respect for their contributions and to recognize the role of treaty making in what is now Toronto. For those of you who might not be familiar with the Economic Club, we are one of Canada's national podiums of record and a nonpartisan national public policy platform that unites leaders, innovators, and experts to discuss and address key issues shaping the future of our country. Our foundation is firmly Canadian, but our influence spans well beyond our borders. Our commitment to fostering collaboration and promoting thoughtful debate continues to drive so much of the work that we do. The Economic Club is more than just an event podium. It's a platform to bring together transformative ideas, helping to guide Canada towards a brighter and a more prosperous future. Now, we know luncheons like this one would not be possible without the generous support of our sponsors. So a big thank you to Healthcare Excellence Canada for making today's luncheon possible, and to our venue sponsor, the Sheridan Centre Toronto. Let's give them a warm round of applause. Now, it is my pleasure to introduce Dr. Jennifer Zelmer, President and CEO of Healthcare Excellence Canada. Dr. Jennifer is going to open up our event today with her opening remarks. Let's give her a warm welcome.
Thanks so much, Stephanie, and thanks to everyone at the Economic Club of Canada and everyone who's joining us here today to be part of this conversation focusing on scaling what works in health and healthcare. And to me, health and healthcare at their core are all about people. People who need care, people who provide care, the communities that they're all part of. So that's where I thought I'd start our conversation today. Start by sharing with you a conversation that I had with someone who I'll call Claire when I visited a long-term care home in Quebec. Claire, every Sunday, she visited her father, Mark. He lived in long-term care, and for months, she told me those visits followed a pattern. He was hard to rouse. He was slow to respond. The man who'd coached minor hockey for 30 years and could recite every single playoff run from 1967, he didn't always seem to be there anymore. When Mark had moved into long-term care, he often seemed frustrated. He'd bang angrily on the glass of the nurse's station every time there was a meeting there, sometimes lash out. And the busy care team mainly managed these behaviors with medication because nobody had the tools to do things differently. But one day the care home invited Claire and Mark and the care team together. And they weren't just talking about medications or how the bruises from Mark's recent fall were healing. They were talked about what mattered to Mark. Because Mark had dementia, but his behavior had meaning. And so they unpacked the fact that, for all those years being a coach, Mark had spent his life leading teams, and now he watched, shut out from every staff huddle. So they updated his care plan. The care aide gave him a clipboard, welcomed him in. And with approaches like these, tailored to Mark's unique needs, they were able to safely reduce his medication. And not long after, Claire came for a visit and she heard her dad before she saw him. And he was in the common room and he was holding court with another resident about long ago playoffs. And Claire told me when she left that day, she felt like she could breathe for the first time in a long time. Because her father was still there. His care just hadn't been organized around what mattered to him. And Mark's story isn't unusual. CIHI estimates that 1 in 4 long-term care residents take antipsychotic medication without a diagnosis of psychosis. A team in Winnipeg pioneered non-drug approaches that are better for many patients living with dementia and their families. The breakthrough was learning to see and connect with the person, not just with their behaviors. So then we had the opportunity to work with care homes in other provinces and territories, and then across 3 Atlantic provinces and Quebec, to adapt and scale these types of approaches. And over half the time, medications were stopped completely or reduced. Better for residents and families, better for the care team, and better for the health system. And we really need better at scale, because if we're honest about it, healthcare faces headwinds and Canadians are feeling them. I'm sure all of you know folks across the country who can't access timely care that meets their needs, or who run into barriers that stand in the way of their health and well-being, or clinicians who face workforce shortages and burnout. This influences the health of individuals and communities. It affects how health systems work or don't for those they serve. And I'm standing behind a podium at the Economic Club, so I would be remiss if I didn't also point out that it influences workforce participation and the health of our economy. Yet, healthcare in Canada, it's full of points of light. We innovate, we prove things work, and we pilot, although maybe perpetually, as Monique Bégin said a few decades ago. But not everyone always benefits from these successes. The challenge isn't actually discovering what works. We do that every single day. It's spreading proven innovations across fragmented systems that are often really stressed so that everyone can benefit, regardless of their postal code. And then we need to go to scale so that proven change reaches everyone, everywhere. Now, how do we do this? It's easy to think about what gets us stuck, and that's important, but I also like to learn from what high-performing health systems have in common. People who've figured out how we should go. And the first thing they start with is designing care around people, not around what's convenient for the system. It's about asking what matters to you, not what's the matter with you. And that simple flip is the basis of an international person-centered care movement. You know, it seems simple, right? It's just a few words. But if we flip the culture in that way, the effects can be profound. Mark and Claire's story, and those of people at the hundreds of long-term care homes who've taken similar approaches, are an example of doing this. And the same principle of centering what matters also allows us to respond to the needs of different communities. Here's a recent example. People living in shelters or on the street may be left out of traditional palliative care, cycling in and out of emergency departments. Meeting folks where they are, addressing their medical needs as well as social and structural barriers that get in the way of health. It's not just improving care, although it does. Equity by design also creates value. So an independent evaluation found that for every dollar invested, there was $1.65 in emergency department costs avoided. Now, we also need to acknowledge that the same types of gaps that fail people who need care can also fail people who provide it. Only 45% of healthcare workers say that they're often or always encouraged to participate in decisions that affect their work, significantly lower than workers overall. The results, well, they're what systems produce when they're organized around institutions and services, not people and the outcomes that matter to them. But it doesn't have to be this way. Flipping this around is key, and it requires investing in the people doing the work and the cultures they work in. Take Edmonton's Glenrose Rehab Hospital. A focus on relationship-centered leadership increased patients' sense of being heard by 32% and dropped negative staff sentiments from 40% to just 2%. Now that's impressive all on its own, but they've also maintained these results for more than 2 years now. So asking what matters to you is the foundation. But high-performing health systems also close the gap between what we know and what we do, building capacity to use the best available evidence to learn and to improve care. For instance, only about a quarter of Canadians, maybe you know someone, maybe you are someone, can see a healthcare provider on the same or next day. Yet we already know proven ways of closing this type of access gap. For the last few months, for instance, clinics across the country have been applying advanced access principles and learning from one another. Already, a primary care team just down the road from here, I had to do my geography as I came into the room, that away, has cut their wait times in half. And local teams like this are doing amazing work. But if they're trying to do that work and policies, incentives, or structures are getting in the way, then even the best ideas will stall. And the reverse is true too. No reform or transformative technology survives long in a culture that grinds people down or misses the mark with those it serves. A good example of what happens when we clear these hurdles comes from paramedics providing palliative care in the home. With this innovative model, about 60% of people in palliative crisis can stay at home where they want to be, rather than being transported to hospital. That compares to the standard 10%. A family member from Newfoundland and Labrador described the difference this way. It enabled my father-in-law to get a good night's sleep. It enabled me to do what I needed to do as a family member, providing comfort. And it was as simple as a phone call. Interestingly, even though paramedics spend more time in patients' homes under this model, they actually spend an average of 31 minutes less per call because they're not transporting patients to hospital and waiting for them to be admitted. The return on investment, $4.60 for every dollar spent. This too is better for patients, better for paramedics, and better for the health system. But scaling across 7 provinces didn't mean just training more paramedics, although that was required. No single government or organization or profession can do this kind of change on their own. It took local changes in the rules about when to transport patients. It took provincial changes to scope of practice. It took federal changes to the rules around administering pain meds. It took everyone. So to summarize, the programs that I've talked about today aren't isolated miracles, and neither are the more than 500 teams that you may have seen outside the door that we work with through Care Forward on advancing care closer to home and community. And I'm willing to bet that our panelists shortly will have some examples of their own to share. All of these advances are examples of what's possible when systems are designed to listen, to learn, to adapt. They engage deeply. They support the people doing the work. They learn, they build capacity to change, and they remove barriers that get in the way of good care. Which, let's be real, isn't easy in a system as complex, as fragmented, as stretched as ours. But complexity simply cannot be an excuse for designing around institutions when people live their lives across them. And when we get it right, the results are powerful. A game changer for me, as a participant recently in Nursing Home Without Walls said. This program aims to support older adults and community before needs escalate and lead to a move into long-term care. From its start in Moncton, it's now spread across New Brunswick, supported by successive governments of different political stripes. And the early results, they're really promising. Use of other health services are down. Use of social supports are up. And 9 in 10 people participating say that it's helping them to stay at home. And 4 provinces beyond New Brunswick are already on deck to take these same principles into their context. So I truly believe that scaling results like these is a core leadership function, that success depends on the choices we make and the environments we create for proven approaches to take hold, to adapt, and spread across different communities and different settings. Because good intentions are enough. We need to create the conditions to allow further, faster, more consistent, more relentless progress. Because we have strong evidence for what works. We know some of the no regrets moves, regardless of what AI explodes or which government's in power. What we haven't always cracked is the consistent will and capacity to imply them everywhere, all the time. And that's where collective leadership comes in. It requires us to shift how we think, where we invest, to nurture trust, to focus on value, not volume, and to cultivate the policy and system conditions that support lasting change, not resist it. Because at the end of the day, large-scale change is made possible by thousands of smart, practical decisions moving in the same direction. So Canada's biggest healthcare challenge may not be discovering what works. We're pretty good at that. It may be learning how to make what works available and adapt it to everyone who could benefit. And that's where we all come in. I'm sure you're busy. You wouldn't be here today if you didn't care about health and healthcare. So wherever you sit, whether you're a patient partner, whether you're a health or institution leader, whether you have spare capacity to care and influence, I invite you to think about and to keep thinking about what can you do today, now, to push for better. Because when you're in Mark and Claire's shoes, no matter where you live, no matter what you look like, no matter who you know, you need to be able to trust that the high quality, safe care you want and deserve will be there. Thank you so much.
Thanks, Dr. Zelmer. So here to join Dr. Jennifer on stage to partake in our panel discussion is Mohit Arora, patient advocate and strategy lead at Full Culture. Dr. Kate Mulligan, founding scientific director, Canadian Institute for Social Prescribing, and Stephen Samis, president of Samis Health Policy Consulting. Let's give them a warm welcome.
Thanks so much, Stephanie, and a big welcome to our panel for today. So our panelists are going to start with really setting the table in terms of their perspectives on today's topic, but we want to provide an opportunity for everybody in the room to be involved in this conversation as well. So just before I hand it over to Mohit, I will let you know that the lovely flyers on your table have a back to them. And the back has a QR code where you can pop into the conversation and add your ideas and questions to the conversation today. Mohit,
Yes.
over to you.
Sure. Thank you. Thank you, Jennifer. And it's a pleasure to be here with everyone. It's an exciting time right now, right? There seems to be a lot happening in healthcare, especially obviously, the big conversation is around AI advancements. It's moving fast. I don't think we've ever seen a technology that's moving as fast as AI is. But it's interesting, there's this mantra in technology where they say fail fast, right? You fail fast, you learn, you iterate. The problem though is that we're in such a race for AI supremacy that right now we're adopting that same mantra, fail fast, but speed done without speed's dangerous, right? In technology, failure lands in a server. In healthcare, it lands in a human being. And that's a very different situation, and we have to be very conscious of that, right? So one thing I would love to know, one thing I love to ask everyone is when you're in these meetings, Are you asking how are we going to scale, or are you asking, are we failing safely? Are we setting up ourselves to understand how the failure was not going to live in a human being, in a patient? And it's really important to me, right? So I'll give you some context. Myself, I'm a very frequent flyer of the healthcare system. I spent over a decade as an inpatient and several decades, may not look it, but I probably do, several decades as a very heavy user of the healthcare industry. And what I've learned is that those moments when you're about to introduce a new technology, you're going to scale a technology, those are some of the most important, but also some of the most dangerous moments. Until then, the danger is actually in the success. Because when you have a pilot, you were talking about the pilots earlier in that quote from Monique Beijing, which I love. But up and until that point, your pilot is done in a controlled environment, right? There's very specific parameters, and it's so easy to fall in love with the success of a pilot and think we can copy and paste it elsewhere. But I think we're scaling the wrong thing. We're oftentimes scaling systems when really we should be scaling the process. How did you get to that output, right? Who was in the room? What were the questions being asked? What were the objections or the flags being raised? Those are the things that's where everything gets shaped. It's those conversations. So when we learn to apply how trust is actually built, the trust is in the relationships. It's not in the system. The system is never having an inherent trust. So if we take that approach a little bit differently and we stop just trying to copy and paste the system elsewhere, and we recognize who did we think to bring into the room? What were the questions that we were asking them, and what were the questions they were asking us? We can now adapt and scale a system that makes sense for the different communities, the different environments, the different patients. And that's the big difference between input and collaboration. Input is when you just send out a patient survey and ask everyone well, what do you think about this? What are you going to do with that? What are you going to do with that output? You're just going to check it off a list. But if you actually have true collaboration, you're bringing people in from the very beginning. You're having them be part of the decision making. That's when you have true collaboration, right? We were talking about this earlier. Oftentimes when you're making these procurements and you're deploying something, there's a term we use called buy-in. But if the community itself did not tell you what's important for their buy-in, you're going to be force feeding this system, whatever it may be. But in closing, I just want to give an example. Look at the term that we're using here today. We're talking about healthcare, right? We're not talking about medicine. Medicine is based in science. Healthcare is based on relationships, and it's the relationships where the trust lie. Thank you.
Thank you so much, Mohit, for starting us off. And I suspect some of the themes may continue as we go. Kate, you're up.
Thanks, Jennifer, and thanks, Mohit. So I'm Kate. I'm an associate professor at the University of Toronto, and started up the Canadian Institute for Social Prescribing after learning from a pilot. So we tried out social prescribing at community health centres in 11 Ontario communities in about 2018, 2019. Really different kinds of settings where people adapted the principles of social prescribing in their own way for what mattered to them and to their communities and what their strengths were. And the results were so promising, so off the charts, that I quit my job and started this Canadian Institute for Social Prescribing because I wanted to see it scale. I wanted it to be equitably accessible to all of us across our country. And since that time, it has grown to be present in every single province across the country. Universal in 2 provinces, British Columbia and Manitoba, and having my first territorial conversation with Yukon later this week. So it's really, really grown quickly. And it's mostly grown by not plugging and playing pilot models in sort of trademarked and rigid ways, but by learning across boundaries and differences from one another based on principles over processes, starting with what's strong over what's wrong, both with sort of patients and communities, but also with ourselves as systems and structures, where there's readiness to do something differently, even if it's a very small step. And really thinking about this as systems change work, in which we make the road by walking. So we don't have to produce all of the evidence up front. We can learn as we go. And we can do that by having learning, health, policy systems and practice systems. So not just within an organization where we have cycles of learning and doing, but really bringing together all of the interest holders together early and often to talk about what we want to accomplish, how we'll know if we're getting there, and what's a feasible and reasonable and meaningful and sustainable way to keep that learning going. So for example, with Healthcare Excellence Canada, I've developed a community health guidance for policy and systems tool, Community Health GPS. And it just provides sort of a conversation guide to bring decision makers, funders, providers, community members, patients, caregivers, and so on together to decide together. So we're not imagining what funders want to know from us or decision makers might think is important. They can be there and tell us. And then providers can tell what's feasible and meaningful and sustainable in their practices. And it's been very successful in the places where we've tried it out in helping people focus in on what matters to them as systems and as communities. And in so doing, it gets to something even deeper. And my friend Jennifer Wallace, who's a journalist in the US, has written some really important work about mattering and how, focusing on what matters to you really helps to get to that underlying message that you matter. And that's not something we always encounter in our experiences with healthcare. Sometimes we do. Sometimes we feel like we might be imposing or be a burden, right, on a stressed system. But a system that really focuses on mattering shifts that in a way that helps us rebalance structure and agency. So I've been spending this year back and forth from the US learning about healthcare, working with, amongst others, the Federal Reserve Bank of New York, of all places, who are really interested in social prescribing as a tool for economic development and community support. And all indications are that it will be. So we, in Canada, have modeled $4.43 return on investment in terms of social and economic participation and healthcare savings for social prescribing. A new report out of the UK, based on actual experiences with social prescribing, shows a £9 return on investment for their work in social prescribing. So it is indeed very promising. But there's often a focus on the agency of people and communities because they've long been left out by government and have to figure out how to roll up their sleeves and get things done. Here in Canada, sometimes there's an overemphasis on the structure and waiting for some larger system to come and make a change for us. And what we're learning through this work on scaling up social prescribing is we got to have a relationship. It's got to be in balance, and it's actually good for us to take ownership over our own health. That's the basics of health promotion. And when we can provide the structures and supports and resources for people to do that locally, that's when we see real thriving. And then that's the enthusiasm that comes from that and the positive data is infectious. And so we see it growing all across the country. And when we're ready for it, we'll be able to provide that broader structure for those places that need help catching up.
Great, thanks so much, Kate. And infectious in the best possible way, rather than in the other kind of way. Context matters. Stephen, over to you.
Okay, thank you, Jennifer, and thank you, Mohit and Kate. I thought I would kind of come at this from really where I've come from in my career, which is really at a precursor of Healthcare Excellence Canada, when it was the Canadian Foundation for Healthcare Improvement, and then also from a policy perspective when I was Deputy Minister of Health and Social Services in the Yukon. Delighted to hear you're doing the social prescribing up north. That's great. And I thought, I was thinking about what are some of the real enablers that allow these kinds of things to happen or not in the country. And one of them is, and I was not paid to say this, I'm just saying, is I really want to just note the importance of the pan-Canadian organizations, these intermediary organizations who are not government, they're non-governmental, and able to work below and in and around some of the jurisdictional challenges, bun fights, issues that play themselves out in the country. Because and I've sat at FPT tables where that happens periodically, and I now live in Alberta, need I say more? The organizations like HEC, Canada Drug Agency, Canadian Institute for Health Information are able to work with those who are delivering care, work with delivery systems, work with policymakers in a non-threatening way, in a really enabling way, in a facilitative way. And in our country, that's really, really critical. We really do need to embrace the fact that we have these organizations who are able to bring people together. And that's the other thing. They're able to bring people together across siloed health systems, across jurisdictions, across institutions. I was just speaking to someone this morning who works at Michael Garron here in Toronto, who was saying, one of the great things about participating in the programs of the Pan-Canadian organizations is that, it gives me an opportunity to even connect with the other hospitals that are in Toronto. And my colleagues that I'm not always connecting with, that I'm not always learning from. So we really do need to come together and we need to learn from each other, including what works and what's not working, what's challenging and what's enabling. And so that would be the first thing. The second thing I thought is we do need to contend as a country with what has been termed our quote unquote perpetual uniqueness syndrome in Canada. This notion that something that works in Saskatchewan and Alberta couldn't possibly work in New Brunswick or Nova Scotia. So there's this challenge that we are all so different from each other that we can't spread and scale because local context is too different. The flip side of that is local context is really important and it really matters. And we need to be in a process of adaptation and adoption. We need to respect local circumstances, but don't allow local circumstance to be a barrier to doing the right thing. Jennifer talked about that story of Claire in Quebec. I was part of an earlier iteration of the appropriate use of antipsychotics in long-term care. I remember hearing about Richard in Winnipeg, who was exhibiting the same kinds of behavioral challenges in a long-term care home in Winnipeg. And then somebody said, well, tell me a little bit about Richard. Who was Richard? What did he do in his life? Oh, well, he was a University of Manitoba professor. He's a retired professor from the U of M. Oh, and what did he teach? And what did he love to do? He loved nothing more than marking papers. So the staff started to take, paper that was just, instead of recycling it, they would take papers and staple them together and give them to Richard and told him that these were student papers. And then there's this, and I remember it's almost heartbreaking just watching this, seeing this image of Richard on the floor in his long-term care room with papers spread out amongst himself and a pen in his hand, happy, marking papers. That is happened in Winnipeg. Claire is in Quebec. It's the same phenomenon. And learning from each other and doing the right things for those people, regardless of where they live, is really important. But it is always a process of adaptation and adoption. We have to adapt to adopt as we try to move innovation from one part of the country to the other. And then the other thing I wanted to say is we do, as in healthcare in Canada, have to identify and learn to find a way to better enable healthcare leaders to do the work they need to do to innovate and take risks. There's the over-politicization of healthcare in the country can be a barrier to spreading and scaling. There's the people who are running health systems need to have the psychological safety and the ability to take risks and to innovate without the fear that there's going to be a recrimination if they make a mistake or if something doesn't work, or that the system is just going to be organized around them overnight. So when Jennifer talked about that example of the work that's gone in New Brunswick under successive different governments of different stripes, we need to see more of that. We need to allow the people who know the healthcare system, who have knowledge and experience in healthcare, who are working with patients, who are working with the providers to be able to do what they need to do to take risks. And so as a country, I think we need to have a conversation about how do we depoliticize healthcare in Canada so that those running systems are able to run them well, and where we can take a risk and we can do the work we need to innovate, spread, and scale.
Thanks so much, Stephen. And I think you can see why when we had the pre-call, I was confident I could just talk to these guys for like the next month. We'd be fine. But we do want to have a broader conversation. So I'm going to hold back my questions and I'm going to jump to the ones on the iPad. So if you have questions that you'd like to put in or comments that you'd like to put in, don't hesitate as we go. And I think, Stephen, you've actually teed up this first question really well. which is, scaling best practices across the country does require governments, provincial, territorial, and I would add, although the commentary didn't, federal, to work differently and more collaboratively. And are you seeing signs? What signs do you see that people are stepping in to that world?
Well, I think we're at a moment right now in the country where I think we recognize we need to work together. We need to come together. I think we're, in spite of some of the things that we're reading about in the media, I think Canadians are coming together. And I think the most powerful thing that we can do as members of the public and as Canadians is send that signal to our governments that we do want them to collaborate, that we do want them to work together, that we want to see better equity in what's available to citizens from one place to the other. And so, we can talk about governments working together, but what do governments really do significantly is respond to what they are hearing from their constituents, what they're hearing from their own publics. And so we all have a role to play in sending that message to governments that we want to work together. We want to see progressive change happening from one part of the country to the other. But I also think that there are tables that are set up where officials are able to come together and learn from each other. And I think that's really important. We need to have governments of all stripes, regardless of their political affiliation or what level they're at, to enable their officials to come together, to meet, to work together, and to learn from each other so that we are able to understand what's happening in one part of the country and then have other parts of the country benefit from that.
Thanks, Stephen. And Kate, you're about to flip up to the Yukon. Anything you wanted to add?
I think that just as important is that collaboration and cooperation within governments. So even within ministries of health, for example, teams might be competing for resources or be siloed and not know what's happening in the office next door. So that's where these learning systems really shine. They can help us with what the health economists call the wrong pocket problem, right? Where somebody is paying for the intervention and someone else is benefiting from it, right? Even within the Ministry of Health, those aren't always accounted for in a shared way. But when we come together to decide what our goals are and how we're going to evaluate them and how we're going to learn, then we can come to some shared accountability. And that's where, around the world and to some extent starting in Canada, we're starting to see a bigger emphasis on well-being budgeting and indicators of our quality of life overall that help bring us together across differences, even within governments. And so, processes that support our relationships and collaboration and mandate that in ways that are accountable to one another and accountable to communities are the things that will build the relationships that keep this going forward. And so Mohit says health care happens in relationships, but so does health itself, right? We literally exchange with our environments. We literally need to be in relationship with other people. We literally are whole people with families and communities and lives. And that, this broader, the broader conditions for that can be established. And governments have a really important role to play in showing leadership for that. And those of us working in these organizations that can bring people together across different sectors and government and so on have an important role to play also in showing the art of the possible so that we can build the evidence they need. If you need a made in Alberta, made in Saskatchewan, made in Manitoba version, we will do that. We will help you get there so that unlocks your door to do the next part that we can't do, but you can if you're in government.
Fantastic. Maybe I'll switch to the next question, and Mohit, bring this one to you because you talked about tech as part of your conversation. And so this question is really about what's the argument for or against, what's the place of virtual care in a Canadian context in terms of driving to excellence?
I mean, virtual care, I personally love it. One, there's a lot of people who have different accessibility issues, different, like myself, I'm immunocompromised. So there's certain periods during cold or flu season, I'm not trying to be outside, right? And the opportunity to be in a virtual care appointment rather than go into a setting where someone might be seeing the doctor because they're sick. I think, one, it's fundamental, but I think when we're talking about tech, the introduction of tech and the advancement of different technology tools being provided to patients is what helps us get better with our community care, right? Oftentimes, like we say, like business to business or business to consumer, every single human being in every environment is a consumer of something. And if you're using your technology and the technology is being made to help you in that moment with what you need, you're going to adopt it. I do think there's still a need, obviously, for in-person because you do not want to replace that relationship with a screen. But the option does need to be there. Everyone has a different comfort level. And I do think actually healthcare settings are one of the best places for advancements of technology where we're able to see what we need to continue to develop, what we need to continue to scale, and where we introduce it. What do we patch? What do we fix? And what do we sunset? What doesn't really make sense for us to offer? Because I'll say oftentimes these purchase decisions for tech, whether it's an AI scribe or whether it's a telehealth platform, oftentimes the conversation about that's happening before procurement is only from the people who are making the purchase. It's never the people who are receiving it. If you're not including the recipients of what you are offering, then you're not really feeding into what they need and what they want, especially what they want. Because if you could have all the science, you could have all the medicine in the world, but if the relationship's not there and the person does not know to access, how to access it, who you are, and they don't trust, which is a whole other conversation we could get into, trust, it's never going to be adopted. So yeah, I do think it's a tricky balance, but it's absolutely fundamental.
Fantastic. I am watching the countdown clock, so I'm going to combine two questions into one for our last question, and then we'll give each of you an opportunity for a key takeaway. And Kate, I think this one might be one for you to start because both of these questions are around early stage innovation to scale. Both pilots often have guardrails for seed funding or have loosened them, right? So what happens when we move into a different environment that's a more real world environment? And specifically, how does that work in a context where we may be building the evidence as we go, as you spoke about?
Yeah, I mean, that's a great question. And that's really the crux of implementation science, right? Where we're learning by doing, gathering the evidence, and adapting as we go. So I think one distinction between the early innovation in social prescribing and other models, capital M, in healthcare, is that in social prescribing, we strongly encourage people to begin as they mean to go on, so that its sustainability and feasibility and meaningfulness and so on are built in from the beginning, so that it isn't just sort of a lab type model that's not replicable, or a unicorn research study that brings tons of resources, or brings a link worker or a community support worker into community and then takes them away. So that's not the approach that we encourage. We want to begin as we mean to go on, even if it means starting very small with the resources we have and growing from there, starting with what is strong. There is a lot of untapped capacity. I mean, we are a stressed and strained system in many ways, but there are so many people who have something to give, something to offer. And what we learn in the work like social prescribing and, caregiver and patient leadership is that there's a lot of knowledge. There's a lot of capacity. What we need is to better connect that and build the plumbing around that, right? To better connect, use that to be an infusion of energy into the system. So that means that, when we want to do the scaling, we don't have to worry about some of those problems that come when you've taken a very capital R research approach. And I really see the distinction in the US, for example, where I met an innovator in California who has trademarked the term community as medicine. Right? So millennia of human knowledge just, privatized. That's the opposite of what we want to be doing here. We don't want to create lots and lots of trademarked models that nobody can share and use. We want to just collaborate, work together, and share knowledge. And it's a lot easier if we give ourselves permission to start small and build on what's strong. So a lot of the work I do involves going to places saying, you're doing great work, like do a bit more of that. And I come back a year later and people have leaned into it and grown in their own locally adaptive way. And so those kinds of looser, more systems type feedback oriented approaches are the way to go.
Awesome. And Kate, I think you've actually just also answered another question that came in around how do we actually share lessons about scaling? So you gave some good examples on that front.
Yeah, communities of practice across provinces have been hugely important. I think technology has really enabled that. Like, so during and post pandemic, we're much more comfortable hopping on Zoom together than we had been before, for example. But getting together in the same room is also something that can't be beat. So it's really nice to have people able to convene and have organizations willing to spend their money to send people to be around other humans. It's well worth it. So I think that sharing is really important. And then the other piece is also, building the evidence base. So, back in 2018, 2019, we had no peer-reviewed publications about social prescribing and its impacts in Canada. We now have probably over 40 just in the last few years, because we realized how important it was to build that evidence around demand, around feasibility, around impacts for different people, different circumstances, what works for whom, under what circumstances, the financial, right? All the different types of evidence that matter in moving policy. It's not just outcomes, health outcomes, or even health systems outcomes. It's a range of things. So trying to find lots of different venues for that in the media, in scientific publication, in policy conversations, public and private, just continuing to build those conversations and being willing to go where the action is, where people have an interest and you see some strengths and some opportunities.
Great. Thank you so much. So as we close today, we wanted to give each of our panelists an opportunity to leave you with a gem, a gift to take away. And I want to make sure, Mohit, that you get the last word as our patient voice on the panel. So, Stephen.
Okay. I think one of the things that we really need to do as we're thinking about what works and how do we spread and scale across Canada, and I couldn't reiterate enough what Kate just said about we need to enable people to come together. We need to meet with each other. We need to learn from each other. We need to be able to travel across our country and understand what's happening in different parts of the country. But when it comes to spreading and scaling in healthcare, I think we have to ask ourselves not only what worked and why did that work, but also what didn't work. Why did this not stick? Why did this not scale? Why didn't this spread? And the appropriate prescribing of antipsychotics in long-term care is an example. We saw that go down before COVID. We saw it come up before COVID. It's kind of plateaued. I know we had teams in the Yukon that were very successful and have lost ground. So, some of that, of course, is part of the pandemic. But when things don't work, it really behooves us to say why not, what didn't. Some of our best learning about spread and scale can come from that analysis of what didn't work, what didn't stick, and what didn't spread, than from those things that do.
Kate.
I love watching social prescribing happen in all kinds of different places. And one of the really cool ones I'm seeing right now is at the University of Michigan. And in their sports program, they have a whole slogan around something like "Hail to the victory," right? And they won the NCAA basketball finals this year and stuff. But there's a whole lot of pressure on students, and student mental health is terrible. And so they've created a whole social prescribing program around "Hail to the fail." And just being willing to suck at something, try something new. And so we can model that by sharing. I just want to, emphasize again, as Stephen says, sharing what hasn't worked bravely and courageously, and being willing to try things that might not work. So not only sharing the benefits, but also the fails because we tried something new. And also, I think on the other side of that same coin, and it's not going to feel super comfortably Canadian, is share what does work really well. Don't be shy to share what's working. That's how we've grown social prescribing across the country. That's how we've grown to now social prescribing in 40 countries around the world. Because people like me go to, I just came back from Japan where I can say, it's happening very well in Canada. Wouldn't you like to, catch up? Right? And then somebody from Japan will be able to come here and say, we're doing it very well in Japan. Come and be like us. So in that has really helped. It's helped to get that sort of healthy curiosity and competition amongst countries to see what's possible. So don't be shy to share your fails and your successes loudly. And if you need help doing that, look to some of these pan-Canadian organizations who would love to celebrate what you're doing.
Thanks so much, Kate. Mohit.
Thank you. Ditto to what both of you said. I love, earlier, Stephen, you were talking about the importance for pan-Canadian organizations. And I think that that's also applicable for patient partnership programs, which it's funny. I'm a patient advocate, but I'm also an advocate for patient advocacy and for patient partnership programs. And oftentimes, one of those reasons too is, like you said, share what works, share what's a success. There's no training program for a patient to tell you what they're going through, right? I often use this expression that when you're listening to a patient partner who's speaking, sometimes people are speaking from the wound and it's still very emotional. But when you're trained to speak from the scar, you're able to take the data from it. The emotion is still important, but you're able to take the information from it and communicate it in a very appropriate manner. And I think when you have more patient partnership programs from the very beginning and pan-Canadian, you're able to learn from one another. That's part of the training. You never know how to express what your experience is unless you're hearing that language. And we need more opportunities to develop that language, to learn that language. So I'll just say, we've been talking a lot about relationships. We've been talking a lot about trust. And that's the key for me, trust. Technology moves at the speed of code. Healthcare moves at the speed of trust. So how are we including trust in what we're doing and how we're scaling?
Thanks so much, Mohit. And one of the ways of building trust is in relationship, like we all are today. So thank you to everyone who contributed to this conversation. Apologies that I wasn't get to every single question, but some of our panelists may be hanging around, so there may be an opportunity to ask them afterwards and hopefully to continue the conversations you've been having here today as well. So please join me in thanking our panel.
And a final thank you to Dr. Jennifer, Mohit, Dr. Kate, and Stephen for such a great conversation. And as Dr. Jennifer said, I know there was a lot of audience questions we didn't get to, but stay tuned. Maybe we'll do a part 2 in our next season. And a big thank you to Healthcare Excellence Canada for helping facilitate today's event and making the luncheon possible. Now, this marks the last event of our season. Our events will resume in September. Now, until then, please mark your calendars for November the 24th, where we will be welcoming Tiff Macklin, Governor of the Bank of Canada, for a podium address. We'll have more details in the fall, and you'll be able to see all of our other healthcare events launch in September. Thank you for spending your lunch with us, and have a great afternoon.